Hi, I'm Bob Wilfert, one of the family physicians working out of the Baldwin building and one of the family doctors working as part of a team to make your family medicine clerkship. I'd like to talk with you about doing a physical examination as part of your video visits. If you're like me, when you took your advanced and basic doctoring courses a few years ago to get ready to learn how to do physical exams, you never thought about trying to apply those skills via a video chat, and that can be a bit anxiety producing, or at least it has been for some of us. And so in this video I'm going to talk about how to do a physical examination for the respiratory system while in a video visit. I think it's most important when we're thinking about how to do a physical examination in a video visit to realize that just like in a face-to-face visit that you are more accustomed to, most of the information that we get from our examination actually comes from listening to the patient's history and not from the physical examination or the maneuvers that you perform. And so while the patient is giving us their history during the physical examination, you can actually have a second channel processing, not only listening to their words but watching how they give their words. So some people are able to speak in complete paragraphs without pausing to take a breath, in which case you can make a kind of an overall gestalt about how well they're doing. Some people are struggling so much to breathe that they lean forward into a tripod posture, and you might notice, depending on what they're wearing, that they have worked so hard to breathe for some time that they're cachectic, that they've changed muscle mass. They've burned so much energy all day long that they have sarcopenia, a loss of muscle mass, loss of obesity, because they're burning energy just to breathe. Those people look wasted and usually have pretty advanced COPD. Not only can we think about how much effort they're giving to their communication or to their posture or to their muscle use, but in a little kid in particular, you can sometimes see nasal flaring. Or in an older person, you can see signs of obstruction. Let's think about signs of obstruction a little more. So when we're thinking about signs of obstruction in the physical examination of the respiratory tree, there are two techniques that you can do, just you and the patient, without even involving a family member or facilitating your examination with the help of like an LPN or a nurse. The first of those that I'd like you to consider is a forced expiratory time test. In this test, you ask the patient to empty completely and then take the biggest in-breath that they can before blowing out as completely and as quickly as is possible. Now, if I was in the office, I'd pull my stethoscope on their neck so that I could hear when the last little breath was leaving. But on the video, you can just listen and watch. Usually when the patient takes their gasping in-breath, they sort of giggle because it is a silly test. It turns out that the likelihood ratio of a significant obstruction in the airway goes up sixfold if their forced expiratory time takes more than 6 seconds. If you can empty your vital capacity in less than 6 seconds, you probably don't have asthma or COPD. There's a second test for obstruction that I quite like. It's called the Hoover's sign. Hoover was an interesting guy. He's from the 1920s. He wrote 2 signs. The other one was for fake and low back pain. This one is to test for obstruction. If you ask your patient to hold their fingers on the bottom edges of their rib cage, in a normal person, when they take their largest in-breath, the fingers should separate. The angle between your fingertips should become more obtuse. But if a person has a large AP diameter and is obstructed with an unusual diaphragmatic excursion, instead of separating, it'll come out at you, and the angle between your fingertips becomes more acute. So becomes. And so simply by watching that forced vital capacity while they're marking their costal margins for you, you can get an idea of who's obstructing and who isn't. The likelihood ratio for this is not quite as good as the forced expiratory time, but it's still quite good. It's about 4-fold. Both of these tests have really good intra-observer reliability. Their kappa values are about 0.8. As you've asked your patient to do the forced expiratory time and to do the Hoover's test, you're going to naturally be seeing how they use their fingers And you might then notice whether they're clubbed or cyanotic. And as they giggle with you about how silly it is to do this over a video chat, you might notice if they're not only able to speak in complete paragraphs, like you had observed during the history, but if they tend to auto-peep, if they're using their lips to create a little back pressure and stent open those tiniest airways. Like the Hoover sign in the forced expiratory time, noting pursed lips breathing increases likelihood ratio, not quite as much, more like 4, not quite 6. But like the other tests, this also has very good intra-observer reliability. There are some additional elements of the physical examination for the respiratory tree that you can do that might require the help of a second person in the room. And in this situation, your patient would actually not be the examiner, but instead you would be speaking with their family member or friend and asking the family member or friend to check for fremitus. Remember, we're going to ask them to use their pinkies and to put those pinkies on the person's back. I know that this test is written often as the 99 test, but it was originally a Germanic test. And in German, 99 is pronounced 99. The oi sound creates more vibration. So what we want to do, and you will instruct your friend, the friend of your patient, to put their pinkies on the person. And then what I need you to do, patient, is say boiling oil in a really loud voice.
Boiling oil.
I also often ask my patients to say boy toy, because that's more fun. But it's the oi noise that really makes the vibration. Say that again for me, would you?
Boiling oil.
And again.
Boiling oil.
And so we ask people to do that a few times. Say, hey, feel it a little lower, feel it a little lower. And then your examiner will tell you which pinky they feel the vibration in more than the other, or if they're the same. Here's another test that you can do with the help of one of your patient's friends or family members. That facilitator for you was already behind them to do fremitus, but now we can have them place their hands on the back of the patient. Say, hey, spread your hands like this and put them on the back of your buddy. And now, please, patient, take the biggest breath you can in. And the patient should feel, or excuse me, the facilitator should feel their hands move like this. And you could do that in front of the camera and say, hey, now, facilitator, is only one hand moving? Is the other hand moving? Are they moving in the same rate? And that's a way for you to get a sense of if there's symmetric excursion or if there might be splinting. Now, if you've got yourself a facilitator who seems to be working really well with you, you might be able to coach them through a little bit of percussion. The way I've described this to people is to imagine that they're looking for the best watermelon at the grocery store. And most people will know that because it's common for people to be taught to thump the melon to make sure it's right. And so for us to say, well, put your fingers on your patient first and then thump your finger isn't very hard description for the facilitator to understand. It might be hard for your facilitator to describe for you if something sounds more hollow or more dull. But what you'd be looking for isn't those words, but instead a change as you move superior to inferiorly across the chest wall. And your facilitator might be able to tell you that there is a change. There's a couple other things to think of. If your patient has a respiratory history, they might have a peak flow meter at home. And if they don't, you should get them one. You can prescribe a peak flow meter through the DME tab in Epic. But peak flows work great to tell us how a person's reversible obstruction might be functioning. In addition, there are some spirometers that work via Bluetooth with a person's smartphone. They buy the spirometer for themselves at home, and then they can link you their own PFTs to track their function over time. Finally, and this is a bit more expensive, there are now stethoscope heads that similarly work via Bluetooth. The patient places the stethoscope at different places on their body, and you'd hear it live. And I think for the kinds of cases that we might be seeing for most family medicine, that wouldn't be necessary. But I can imagine some of my patients who both have means and interest buying one of these gadgets and keeping track of themselves for us, or using it so that they can get the same quality of physical examination with us wherever they are as they might in the office. And I really mean that the quality would be the same wherever they are. Already some time ago in the late 1990s, there was a study done in an outpatient pulmonology practice in which some patients were given care in face-to-face visits and some were given care via video chat. The charts for those patients were then reviewed in a blinded fashion, and when you compared the action step, the patient's assessment and plan, people who were blinded to the manner in which these got developed couldn't tell which plan steps came from which cases. So it seems that if we're willing to spend the time and be thoughtful about how we do the physical exam, involve others, get a little creative, ask people to move about, we can do a high quality respiratory examination.